Hey guys, Michael here. This is a quick video about procedural sedation. Now, procedural sedation is the safe delivery of adequate analgesia and appropriate sedation in a pre-hospital environment. It's the administration of sedatives or dissociative anesthetics that induce a depressed level of consciousness in our pre-hospital patients, whilst hopefully maintaining cardiorespiratory function so that a medical procedure can be performed with little or no patient memory whatsoever. Now, there are three distinct levels of sedation. First level is minimal sedation, which produces anxiolysis. So basically, the patient doesn't feel as anxious and hopefully is a little bit amnesic to the events. There's then moderate sedation, which is a depressed level of consciousness. The patient will still have purposeful responses to painful stimuli or quite severe or quite noted painful stimuli. And then we have deep sedation, which is practically a state of complete unconsciousness. Patients will only become responsive to deep, intense, painful stimuli, and there may also be some cardiopulmonary depression involved in this as well. Now, generally in the pre-hospital environment, moderate sedation will be more than appropriate for any of the skills or procedures that we would like to apply. So the equipment that you're going to need for your procedural sedation, you're going to need your standard PPE, gloves, goggles, face masks if necessary. You're going to need a patent IV access, IO if you don't have any potential for IV access. You're going to need your pharmacological agents of choice. For this demonstration, we've gone with ketamine and midazolam, as well as a couple of flushes. You're also going to need all of your patient monitoring equipment, so your stethoscope, ECG monitoring, blood pressure cuff, SAT probe, ETCO2 monitoring as well, all built into the lovely life pack that we have here. You're also then going to need your airway adjuncts, your rescue adjuncts. So as you can see, we've already got the nasal prongs attached to the patient. You're also going to need your basic OPA, MPA, and then perhaps your more advanced LMA, ETT tube if necessary. We have suction on standby, as well as good access to a BVM. Now, to perform the procedural sedation, for this patient in particular, this is Steve. Steve is going to be undergoing some transcutaneous pacing. So for the demonstration's sake, I've already pre-applied pads. So these are going to sit up here nicely. You want to obtain a detailed history from the patient. So you're looking at comorbidities that may affect the medication that you're going to use. You're looking at previous anesthetic administration, particularly if they've had poor responses to anesthetics in the past. You want to look at the medications and see if there's going to be any interactions between the medications you're going to be giving as well as the medications that he's already prescribed, perhaps. The fasting status of the patient, when do you last eat? If you are going to have to intervene and do a bit of airway manipulation, what's the likelihood of aspiration? Do we need to be worried of this, as we normally probably would? Drug use and drug allergies as well. So illicit drug substances can have effects with medications we might want to use, as well as if the patient's allergic, we're not going to give it to them. Now, during your assessment of the patient, you want to make sure you're closely looking at your patient's blood pressure, heart rate, rest rate, their GCS. We're going through all of this to make sure that the medication that you're giving, you can trend the patient's reaction to the medication. Any deterioration whatsoever is going to be picked up quickly on the ECG with your cycling blood pressures, your SAT probe, your rest rate, and all that kind of stuff. Now, once we've done all that and we've decided that this patient's in a position that he has adequate airway, breathing, circulation to perform sedation, we're then going to choose our drug of choice. Now, for this, I'm going to use ketamine. Now, we've got an established running 18-gauge cannula in the QFOS. We've made sure this is patent. This has had drugs flushed through it previously to now. Now, we want to position the patient as optimally as possible. For this, he's slightly head elevated. He's probably not feeling quite well at the best of times due to the fact that he's about to have some transcutaneous pacing. Now, before we can administer anything, we want to make sure that we do a bit of pre-oxygenation. So I've started on some nasal prongs. Like I said before, we have our oxygen viver here with all of our oxygen masks. We also have our extra adjuncts close at hand if necessary, if there's any deterioration of that airway. Now, once we've done all this, we're going to administer our drug of choice. Now, for ketamine, a consideration is that you want to make sure that the patient is relaxed as possible to ensure that there's no adverse effects. So we want a nice, relaxed, calm environment. Having a good chat to Steve here. We're going to say that he weighs approximately 80 kilos. Okay, now it's time to administer our drugs, and for this I'm going to use ketamine. I'm going to administer 80 milligrams of the ketamine. So 80 milligrams in this 200 milligrams in 20 mils is 8 mils, and that's a 1 milligram per kilogram dose of ketamine. And of course, once we've done that, we're going to flush that through. Wonderful. Now, once we've done this, we want to wait between 2 or 3 minutes for the peak onset of the sedation. Now, specifically with ketamine, there is quite a lot. There is a likelihood in about 10% of patients of some nasty adverse side effects, such as emergence. Now, if that does occur, what we can do is, let's say that Steve here is not having a great time on the ketamine. Here's some midazolam. We're just going to administer an extra 1 milligram of midazolam to this patient. Okay, so now that we've administered the ketamine and the midazolam, we need to wait that extra 2 or 3 minutes to make sure that Steve's properly sedated, and so that we can go on with our transcutaneous pacing here. Now, during sedation, what we're looking for is that depressed level of consciousness. We can use the APS505 scale: alert, verbal, painful, response to verbal, painful, or unresponsive completely. We're looking for somewhere half between verbal and pain for this moderate sedation. Now, once he's at that level we want, we can commence with our procedure. We want to make sure that we're regularly checking our SATs, our blood pressure, our ECG monitoring, our CO2, our rest rate, just to make sure that if there is any need for any ventilatory support or any other sort of cardiopulmonary support, that we're right on top of it. The patient's not going to have any adverse effects. Now, some potential precautions, complications that we need to be aware of is that ultimately we are depressing someone's consciousness. We are sedating someone to a level of consciousness that is less than what they were initially presenting at for the purpose of a procedure. Now, we want to be careful of the medication that we use. Medications like ketamine and midazolam are fine pre-hospitally. Ketamine is best used for periods between 15 and 60 minutes, whilst midaz is probably only best used for between 20 and 30 minutes. Ketamine is probably a better choice, as it more often than not does not have the cardiopulmonary depression that is sometimes associated with midazolam, and it also doesn't affect naturally occurring airway reflexes, so we're hopefully going to get less likely this patient's going to upturn themselves. There are contraindications for using procedural sedation are patients in which we think the airway is going to be compromised to a point in which it cannot be rescued. Patients that may have trauma up towards their airway, I think, and similar situations like this, we don't really want to sedate them too much, particularly if it's going to be quite difficult to then rescue that airway. Complications include, like I said, we're sedating a patient, we're dropping that conscious. The patient can go completely unconscious. They can lose the protective airway reflexes. They may have unpredictable responses to the drugs that we're administering, particularly with ketamine. And during the procedure, after the sedation, we may not actually sedate them enough. They may actually still feel and cause a bit of pain from the procedure because we haven't sedated them enough. Now, some key documentation to make sure is that your drug of choice is very well rationalized. You've explained why you're using that drug, the dose you're using that drug, the time of administration, any adverse effects if you're using ketamine, and then subsequently have to use midazolam, the time that the midazolam was administered, and how well that affected the patient afterwards. Thanks for listening.